So on to case 2. A 43-year-old female presents with complaints of a rash appearing over bilateral eyelids and a feeling of weakness. Again, pause the video, have a look at the picture, and describe or write down what you see. So this is bilateral upper eyelid erythema with an almost lilac or violaceous colour. This other picture gives a bit of a clue. So what further history would you like to know about this patient? How long has this been present for? What kind of weakness is she experiencing? Is it walking up hills, putting washing on clotheslines, i.e. a history for proximal muscle involvement? Is there rash anywhere else? Are there systemic symptoms, such as loss of weight or night sweats? Is there any loss of hair? Is the rash pruritic and worse in the sun or in sun-exposed sites? Is there any difficulties in swallowing or changes in the voice? At this stage, what is your differential diagnosis? Lupus erythematosus, seborrheic dermatitis, rosacea, allergic contact dermatitis, or dermatomyositis. Where else would you look for cutaneous signs to help confirm your diagnosis of dermatomyositis? Hands, for Gottron's papules and mechanic's hands, which are shown by these pictures here. On the left, you can see Gottron's papules involving the knuckles and the dorsal fingers. And then on the right, you can see what are known as mechanic's hands, looking like there are skin thickening hyperkeratosis and callosities. You can look for ragged cuticles and nail fold erythema and dilated capillaries. You can look for what's known as the shawl sign, which is an erythematous rash involving the neck and shoulders, anterior chest and posterior upper back. What are some of the extracutaneous features of this disease? Myopathy, malignancy, which may occur before, during, or after the onset of dermatomyositis. This is usually solid organs such as lung, breast, GIT, or GUT. And in Asian or Chinese background, 75% of the malignancies are due to nasopharyngeal carcinoma. Another extracutaneous feature of this disease is interstitial lung disease, which is actually usually associated with a low risk of malignancy. There can also be cardiac disease, arthritis, and vasculitis. You have investigated and confirmed the diagnosis of dermatomyositis with muscle involvement. There is no signs of malignancy on history or investigation thus far. How would you then manage this patient? So it's important to tell the patient to have UV protection. Prednisolone is usually required due to the muscle involvement, and this is given at quite a high dose with a very slow taper. And then is often combined with an adjunctive immunosuppressant such as methotrexate, azathioprine, mycophenolate, or others such as IVIG or rituximab. If muscle symptoms resolve, then topical corticosteroids can be used, or oral hydroxychloroquine.